top 10 most common phobias in the world. Definitions, symptoms, causes, and global impact. Introduction: understanding phobias and their place in mental health. Phobias represent some of the most prevalent anxiety disorders globally, affecting hundreds of millions of people and deeply shaping their daily lives, decisions, and health outcomes. By definition, a phobia is an intense, irrational fear of a specific object, situation, or activity that is out of proportion to any actual danger involved. While fear is a primal emotion meant to protect us from threats, phobias are maladaptive, persistent, and often provoke avoidance behaviors or extreme distress, even when the feared stimulus is not present. The degree of fear felt by individuals with phobias can greatly impair professional, social, and personal functioning, sometimes leading to profound life limitations if left untreated. Phobias can be broadly classified into three major types, according to the DSM-5 Diagnostic and Statistical Manual of Mental Disorders, 5th edition. Specific phobias, focused on particular objects or situations. Social phobia, social anxiety disorder relating to social situations and performance. Agoraphobia, fear of situations where escape may be difficult. Each phobia has unique diagnostic criteria, symptomatology, risk factors, epidemiology, and impacts, but they share key features: consistent experience of excessive disproportionate fear, immediate anxiety responses, avoidance of feared stimuli, significant disruption to daily functioning for at least 6 months. This article delves deeply into the 10 most common phobias worldwide. For each, we provide definition, symptoms, likely causes, real-world impact. The discussion draws on global statistics, representative studies, and cross-cultural insights. Cross-cutting risk factors, demographic variations in prevalence, and emerging approaches to treatment are also summarized. A summary table appears at the end of this introduction to aid comparative understanding. Global prevalence of phobias and epidemiological patterns. Phobias are among the most widespread mental health disorders. Epidemiological studies estimate that 7 to 15% of the global population will develop a specific phobia at some point in life. According to the World Mental Health Surveys and other major studies, lifetime prevalence for specific phobias globally: 37.4%, 12-month prevalence, 5.5%. Prevalence rates are typically higher in women, 9.8 to 13%, than in men, 3.3 to 6%, and particularly elevated among adolescents, with some studies indicating rates as high as 19.3% in U.S. youth. Notable patterns: phobias often begin in childhood, with mean onset ages between 7 and 10 years. Most phobias persist for years. In a significant minority, symptoms can last decades if untreated. Socioeconomic, cultural, and environmental factors influence prevalence, with higher rates in high-income and Western countries, though significant cross-cultural variation exists in types and frequencies of phobias. Phobias are frequently comorbid with other anxiety, mood, or substance use disorders, amplifying the burden for affected individuals. Note: prevalence figures are approximate and can vary by country, instrument, age group, and definition. Below, each of the top 10 phobias is examined in detail. 1. Arachnophobia, fear of spiders. Definition: arachnophobia is an intense, irrational, and persistent fear of spiders and, more broadly, arachnids. Classified as a specific phobia under the DSM-5, it goes beyond normal caution about potentially dangerous creatures and results in extreme distress or avoidance, even when there is no real threat. Symptoms. Typical symptoms include immediate anxiety or panic when seeing a spider, even in images or on TV. Avoidance of places with spiders, sheds, basements, gardens. Intense dread before entering environments where spiders might be present. Physical reactions: sweating, shaking, nausea, heart palpitations, trouble breathing, a need to escape, and sometimes fainting. In children, crying, freezing, clinging to adults, or having tantrums. Possible causes. The causes of arachnophobia are multifactorial. Evolutionary theory: humans may be prepared to fear spiders because of ancestral survival threats, e.g., some spiders are venomous, and early detection avoidance increased survival. Learned behavior: observing others, especially parents, reacting fearfully or negative media portrayals can instill this fear. Traumatic experience. A single scary or negative event involving spiders can result in a lasting phobic response. Genetics. Family history of anxiety or phobias increases risk. Impact on life. Arachnophobia can restrict outdoor activities, cause individuals to avoid certain environments or homes, and affect relationships and careers, especially if one's job or lifestyle involves potential spider encounters. Severe cases can limit travel and hobbies and induce panic at the mere mention of spiders. Up to 50% of women and 10% of men report some degree of discomfort with spiders. Clinical arachnophobia is estimated to affect 3 to 15% of people, depending on the population. Claustrophobia, fear of confined spaces. Definition. Claustrophobia is characterized by an intense fear and avoidance of enclosed or confined spaces where escape might be difficult. It is a situational specific phobia, as per the DSM-5. The phobia is diagnosed when fear and avoidance significantly impair daily functioning, such as using elevators, public toilets, or public transportation. Symptoms. Common symptoms include immediate panic or anxiety in enclosed spaces, elevators, subways, MRI machines, shortness of breath, chest tightness, sweating, dizziness, hot flashes or chills, feeling trapped, suffocated, or an urgent need to escape. Avoidance of places or activities that might provoke confinement. Anticipatory anxiety and disrupted sleep in children, crying or tantrums. Possible causes. Previous negative traumatic experience, e.g. being trapped as a child or in an elevator. Learned behavior from parents or close family members with claustrophobia. Genetic predisposition and brain structure differences, e.g. overactive amygdala. Combination with other phobias, frequently co-occurs with agoraphobia or mysophobia. Impact on life. With a lifetime prevalence of approximately 7 to 13%, higher in clinical populations, claustrophobia can limit career options, travel, and healthcare access, e.g., refusal of critical MRI scans, causing significant life disruption and social isolation. Women are more affected than men. Three, acrophobia, fear of heights. Definition. Acrophobia is defined as an excessive and persistent fear of heights, leading individuals to avoid high places such as balconies, bridges, ladders, and mountains. The phobia interrupts daily functioning and can provoke panic even at mild heights. Symptoms. Marked anxiety or panic when at or thinking about heights. Physical symptoms: nausea, dizziness, trembling, shortness of breath, rapid heartbeat. Avoidance of places that involve height, e.g. living or working in high buildings, climbing stairs. Anticipatory anxiety about upcoming situations involving heights. Possible causes. Evolutionary adaptation. Fear of falling and injury is present in humans and animals, likely as a survival mechanism. Trauma. Falling or witnessing a fall can induce acrophobia. Learned fears. Observing significant others panic at heights. Genetic contribution. Family history of phobias is common. Impact on life. Acrophobia can impede travel, recreation, and limit home or employment opportunities. Severe symptoms may occur in environments most consider safe, e.g. staircases, escalators. Estimates suggest 3 to 6.4% of people have clinically significant acrophobia, with women more affected than men. 4. Agoraphobia, fear of open, crowded spaces. Definition. Agoraphobia is a distinct anxiety disorder involving the fear of situations where escape might be difficult or help unavailable. It often manifests as avoidance of open spaces, crowded places, public transportation, or being outside the home alone. Unlike specific phobias, agoraphobia is categorized separately in the DSM-5. Symptoms. Intense anxiety or panic in public settings, shopping malls, crowds, queues, or situations from which escape seems difficult. Avoidance of such situations, sometimes leading to being housebound. Physical symptoms: heart palpitations, sweating, shortness of breath, trembling, gastrointestinal distress. Need for a companion in public spaces. Possible causes. Often develops following panic attacks, as individuals fear experiencing an attack in public and being unable to escape. Genetics, environmental stress, temperament, prior trauma. Family history and comorbid anxiety disorders increase risk. Impact on life. Agoraphobia can be severely disabling, preventing affected individuals from leaving home, working, attending school, or engaging in social life. Prevalence is roughly 1–2.5%, higher among women and in urban environments. Without treatment, it can lead to long-term isolation, depression, and significant functional impairment. 5. Social anxiety disorder, socialphobia. Definition. Social anxiety disorder, also known as social phobia, entails a persistent, overwhelming fear of social situations where one might be judged, embarrassed, or scrutinized by others. It is categorized separately in the DSM-5. Symptoms. Fear of social or performance situations, public speaking, meeting strangers, eating, dating, avoidance of such situations, or enduring them with significant distress. Physical reactions, blushing, trembling, sweating, nausea, rapid heartbeat during anticipation or interaction. Worry about being humiliated, embarrassed, or noticed as anxious. In children, crying, tantrums, freezing, or refusal to speak. Possible causes. Genetics. Family history of anxiety or social phobia increases risk. Environmental factors, early adversity, bullying, trauma, parental modeling of anxiety or overprotection. Temperament, behavioral inhibition and shyness in childhood. Brain structure, overactivity in the amygdala. Impact on life. Social anxiety disorder can lead to school or work avoidance, low career or academic achievement, limited social life, isolation, depression, substance abuse, and in some cases, suicide. Prevalence is estimated at 7% globally, with higher rates up to 12% in some Western nations. Onset is usually in adolescence. Six. Ophidiophobia, fear of snakes. Definition. Definition of ophidiophobia is the irrational and persistent fear of snakes. It is one of the most prevalent animal phobias, even in populations where snakes are rare. Symptoms. Panic, sweating, or immediate flight behavior at the sight, mention, or even thought image of snakes. Avoidance of outdoor activities, certain travel destinations, zoos, or media involving snakes. Physical distress, dizziness, chills, heart palpitations, nausea, trembling. Possible causes. Evolutionary theory. Humans are thought to be hardwired to recognize and fear venomous threats. Learned fear, acquired from parents, media, or cultural stories. Traumatic event, negative or frightening experiences involving snakes. Genetics, family history of anxiety disorders can increase vulnerability. Impact on life. Ophidiophobia commonly affects 3–10% of the population, with higher prevalence in regions where snakes are more common. It may cause individuals to avoid certain leisure activities, outdoor recreation, or even educational work opportunities. 7. Mysophobia, germophobia or fear of germs. Definition. Mysophobia is the intense, irrational fear of germs, contamination, or dirt. Sometimes referred to as germophobia, it is closely linked with obsessive-compulsive behaviors, especially excessive washing or cleaning. Symptoms. Chronic worry about contamination, illness, or infection. Compulsive hand-washing, cleaning, or overuse of sanitizers. Avoidance of public places or social events. Fear of bodily fluids, dirt, or unclean surfaces. Physical symptoms, panic, sweating, nausea, racing heartbeat. Possible causes. Genetics, family history of OCD or anxiety disorders. Environmental factors, trauma related to illness or prior negative experiences with germs. Learned behavior, observing others with similar fears. Media influence, heightened awareness during disease outbreaks. Impact on life. Severe mysophobia can cause life-limiting avoidance, impair social and professional functioning, and strain relationships. It often co-occurs with OCD. Estimated prevalence ranges from 2% to 9%, though subclinical contamination fears are even more widespread. 8. Aerophobia, fear of flying. Definition. Aerophobia is an extreme and persistent fear of flying, ranging from mild discomfort to crippling terror that prevents air travel altogether. It is classified as a situational phobia. Symptoms. Panic, rapid heartbeat, sweating, dizziness. faintness, gastrointestinal distress during the thought or act of flying, avoidance of flying even when necessary for work or family obligations, obsessive research regarding crashes or airline safety, panic attacks at airports or during turbulent flights. Possible causes: traumatic experience, a previous bad flight or hearing about one. Media influence, witnessing or learning of crashes through news or entertainment. Comorbid phobias, such as claustrophobia, fear of enclosed spaces, or acrophobia, fear of heights. Genetic predisposition, family history of anxiety disorders. Impact on life. Aerophobia limits travel for pleasure, career, and family obligations, sometimes leading to financial and relational disruptions. Prevalence estimates range from 2.5 to 6.5% for clinically significant cases, but subclinical fear of flying affects up to 40% of people at some point. 9. Trypanophobia, fear of needles. Definition: Trypanophobia, or needle phobia, is the intense fear of medical needles or injections. While many people dislike injections, trypanophobia involves panicked avoidance that can endanger health when individuals refuse necessary medical procedures, such as vaccines or blood draws. Symptoms: extreme distress, dizziness, rapid heart rate, nausea or fainting at the thought or act of receiving an injection. Avoidance of medical care, even life-saving treatments. Panic attacks during necessary injections. Vasovagal response in some cases. Sudden drop in heart rate and blood pressure leading to fainting. Possible causes: trauma, painful or frightening childhood experience with needles. Genetic factors, family history of similar fears. Vasovagal syncope has hereditary components. Other phobias, anxiety disorders, often co-occurs, compounding the fear. Impact on life. Trypanophobia leads to delayed or absent medical care, avoidance of vaccinations, and increased risk of preventable diseases. Up to 10% of adults may be clinically affected, with as many as 16% avoiding vaccination specifically due to needle fear. 10. Astrophobia, fear of thunder and lightning. Definition: Astrophobia, also called brontophobia or Caranophobia, is a specific phobia characterized by an extreme, irrational fear of thunder and lightning. It often leads to panic during storms. While more common in children, it can persist into adulthood. Symptoms: panic attacks, trembling, hiding, crying, or an urgent need for reassurance during storms. Obsessive weather-checking behaviors. Avoidance of leaving home if bad weather is predicted. Physical symptoms: chest tightness, sweating, nausea, faintness. Possible causes: childhood trauma, experiencing a severe storm or loss during a weather event. Learned behavior, observing parents or peers' fearful reactions to storms. Sensory processing disorders. Conditions such as autism may increase vulnerability. Impact on life. Astrophobia can restrict travel, reduce enjoyment of outdoor activities, disturb sleep, and compromise independence. Prevalence estimates range from 2% to 5%, affecting both children and adults. Cross-cutting causes and risk factors. Although each phobia has unique triggers, several common pathways contribute to their development. 1. Genetics and heritability. Twin and family studies suggest phobias are moderately heritable, 25 to 65% heritability, depending on subtype. Some phobias, e.g. animal phobias, blood injection injury phobia, show especially strong familial clustering. The risk appears to reflect general vulnerability to anxiety disorders rather than inheritance of one specific phobia. 2. Environmental learning and conditioning. Classical conditioning. Direct trauma, e.g. a child bitten by a dog developing xenophobia. Vicarious learning. Observing parents, siblings, or peers showing fear can strongly influence children. Informational transmission. Repeated cultural or media messages, e.g. snakes as deadly, storms as dangerous, can instill persistent fears. Number 3. Brain and psychological factors. Overactivity in the amygdala and dysregulated stress hormone responses can heighten fear sensitivity. Temperamental traits such as behavioral inhibition and trait anxiety increase risk for developing phobias. Cultural and societal factors. Culture plays a significant role in shaping phobias. What is considered fear-relevant often depends on local context. For example, fear of snakes or spiders is more common in regions where these animals pose real threats. Cultural attitudes also influence how individuals experience and express distress, e.g., physical somatic symptoms versus cognitive worries. Societal norms impact whether people report phobias openly and whether they seek professional treatment or rely on informal supports. Gender and demographics. Women are twice as likely as men to experience most specific phobias and social phobia. Explanations include evolutionary predispositions, societal expectations, and reporting biases. Phobia onset typically occurs in childhood or early adolescence, but first symptoms can arise at any age. Demographic factors such as urbanization, socioeconomic status, and education also affect prevalence and treatment-seeking behavior. Symptoms and diagnostic criteria. The DSM-5 perspective. According to the DSM-5, diagnostic criteria for specific phobia, social anxiety disorder, and agoraphobia include marked fear or anxiety about a specific object, situation, or social context. The fear response is immediate and disproportionate to the actual threat. The feared situation is either avoided or endured with intense anxiety. Symptoms persist for at least 6 months. The phobia causes significant distress or functional impairment in daily life. The symptoms are not better explained by another mental disorder. DSM-5 diagnostic criteria, continued. Exposure almost always provokes an immediate anxiety response, disproportionate to the actual danger. Avoidance or endurance with intense distress, persisting for 6 months or more. Significant impairment in social, occupational, or other important areas of functioning. Symptoms not better explained by another disorder, e.g. PTSD, OCD. Physical symptoms, palpitations, trembling, dizziness, sweating are nearly universal. Behavioral symptoms include avoidance and escape behaviors. Psychological distress often manifests as panic, dread, or fear of losing control. The real-world impact and comorbidity of phobias. Impact on daily life. Phobias can be profoundly life-limiting, often leading to disruption of work or career, e.g. avoiding presentations, travel, or confined spaces. Relationship and social life impairment due to embarrassment, isolation, or avoidance. Educational setbacks, particularly in cases of school phobia. Healthcare avoidance, notably with trypanophobia and related fears. Chronic stress, anxiety, and reduced overall quality of life. Psychological and physical comorbidity. Phobias frequently co-occur with other conditions, including other anxiety disorders, panic disorder, generalized anxiety disorder, OCD. Major depressive disorder, seen in 20% of individuals with social phobia in some studies. Substance use disorders, often as self-medication. Physical health consequences stemming from chronic stress or avoidance of medical care, e.g. dental visits, vaccinations. Treatment and management strategies. Evidence-based therapeutic approaches. Cognitive behavioral therapy, CBT, the gold standard for treatment, focusing on cognitive restructuring and graded systematic exposure in vivo imaginal or via virtual reality. Exposure therapy has the strongest evidence base, often leading to substantial improvement or remission. Brief one-session treatments have proven effective for simple phobias. Relaxation and mindfulness techniques. Relaxation training, mindfulness, and stress reduction can help patients regulate physiological arousal, often used in systematic desensitization protocols. Medications. SSRIs and SNRIs may be prescribed for generalized anxiety, social phobia, or agoraphobia. Beta blockers or benzodiazepines can be used situationally, e.g. before public speaking, flying, though long-term use is discouraged due to dependence risks. Other approaches. Virtual reality exposure therapy, increasingly used for phobias such as acrophobia, aerophobia, and others, VRET has shown strong efficacy in reducing phobic symptoms. Support groups, peer support, and holistic or complementary therapies, e.g. yoga, art therapy, may supplement primary treatments. Treatment gaps. Despite the availability of highly effective treatments, the majority of individuals with phobias do not seek or receive treatment. Reasons include stigma surrounding mental health, normalization of certain fears, lack of recognition of the severity of the phobia, cultural and gender-related barriers, which can particularly affect access in lower resource settings. Demographic and cultural variations in prevalence. Cross-cultural surveys reveal variations in both phobia rates and the types of phobias reported. Specific phobia rates are often higher in Western high-income countries, possibly due to greater awareness, labeling, and sensitivity of measurement instruments. Certain cultures report higher rates of animal phobias, particularly where dangerous species are prevalent. In collectivist cultures, social phobia can be especially distressing due to cultural expectations. Ethnic and linguistic factors can influence symptom reporting and help-seeking behaviors. Some cultures emphasize somatic symptoms over psychological expressions of fear. Conclusion: phobias as a major global mental health concern. Phobias are among the most prevalent, disabling, and yet treatable mental health disorders worldwide. While highly diverse in presentation, they share key features: irrational fears, avoidance behaviors, significant disruption to daily life. The top 10 most common phobias, ranging from spiders and heights to confined spaces, flying, and social situations, affect tens of millions globally, with distinct patterns related to age, gender, and culture. The cumulative burden of phobias extends beyond panic and anxiety, impacting chronic functioning and independence, healthcare utilization, e.g., avoidance of medical procedures, academic and career achievement, social engagement leading to isolation, positive outlook. Evidence-based interventions, particularly cognitive behavioral therapy (CBT), with systematic exposure, can be highly effective, providing significant improvement or even remission for most sufferers. Key steps for addressing phobia-related disability: public awareness and destigmatization, early recognition and diagnosis, culturally sensitive clinical practices, expanded access to mental health care. References. References are cited in line with bracketed notation throughout the text. For further reading on prevalence, subtypes, treatment, and epidemiology, consult National Institute of Mental Health, NIMH, World Health Organization, WHO. Peer-reviewed journal articles. Authoritative reviews compiled within this article.